Hello and welcome to this Resuscitation Care Map updates that are to be published on February 13th, 2024 on the Shared Health website. So with this, we're going to review that there's been a couple changes to these care maps. There has been creations of 2 new care maps. The information itself hasn't drastically changed, but it has been broken down into basic cardiac arrest and advanced cardiac arrest. So the first one we're going to look at is C01 basic cardiac arrest. And this care map is used by EMR. So this one is just basic BLS resus. So indication for use of this care map is cardiac arrest due to non-traumatic causes. There is a new trauma arrest care map, which we'll be covering in this lesson, F02.1, to cover traumatic cardiac arrest. So if it's a traumatic cardiac arrest, we ask that you refer to that care map, but for all other cardiac arrests, this would be the one to go to. So contraindications using this care map is if they have a healthcare directive stating not to do CPR. So obviously they have a DNR, we're not going to start with that. Also, if they have obvious signs of death. So with that, if we can reliably find evidence of significant time lapse or since circulation ceased in the patient, such as dependent lividity, rigor mortis, generalized tissue decomposition, putrefaction, torso freezing. Big thing is with that, though, there's a difference between torso freezing versus hypothermic arrest, because hypothermic arrest is a reversible issue we can do during a code. But if we go to do CPR and they are just solid, like it's like pushing a brick, we do not need to continue resuscitation on these patients. Other things we're going to look at as well as injuries incompatible with life, such as decapitation, incineration, so they're completely cooked head to toe. Transection of the thorax or abdomen, so obviously if they're cut in half, we're not going to work that. Substantial destruction of organs or separation of these organs from the body. So if their heart's not in their chest, we're not going to do too much with that. So first thing, like anything else, we're going to open the airway and start doing CPR. So good old LOC ABCs. So we're going to make sure the airway is open. We're going to start breathing for them. And the other thing with that is when it comes to respirations, we have to determine the patient's COVID status. We are not to perform positive pressure ventilation. We are to provide passive ventilation if we are suspicious of the patient actually being positive for COVID. If they're said it's negative, or we're not really reasonably suspecting that it's COVID, let's say like we're highly suspecting our patients having an MI and they code, it's kind of obvious. We can start ventilations without a sealed airway. And just as a side note, please remember that EMRs are no longer permitted to use eye gels as per the current A06 scope of work care map. So once we start CPR, again, good old BLS, that's the most important thing. We've got to keep that brain alive. Once we got CPR going, we're going to start attaching the AD and take a look at the rhythm. So now we have to remember that when it comes to attaching pads on these patients, we want to make sure we use the age-appropriate pads. So if we have a patient that's less than 8 years or 25 kilograms, we're going to use the pediatric pads. If pediatric pads are not available, we can use adult pads, but make sure they're separated by at least 2.5 centimeters. So with that, usually with pediatrics, if we're using adult pads, we're going to go anterior, posterior. So we're going to make sure to put one pad on the front, one pad on the back. The other thing with that as well, if you do have a pediatric patient, make sure you put your Zoll onto pediatric mode, because that way if you do use the AD, it'll give the age-appropriate joulage, because for adults it's pre-programmed to 120 for AD. For pediatrics, it's set to 50 joules on the AED. So we have to make sure we're in pediatric mode if we're going to be defibrillating these kids. So this picture here shows, so in the top, it's got pediatric anterior posterior. So that's if you're using the actual little pediatric pads. So the one goes on the front, it goes to the left of the sternum, and the other one goes on the back in between the shoulder blades. And in the other picture here, I've color coded it. So if you're going to go front and back with the adult pads on a pediatric patient, you're going to put the red one on the back. And this is as per Zoll. Shared Health doesn't really have a standard policy on it. But as per Zoll, it's their machine, so I go with that. We're going to put the red pad on the back, and that will go between the shoulder blades. And based on the size of the child, the purple pad will go on the front. So if you can, try to go left of the sternum. If not, just put it on the center of the chest. The pads can have CPR done on them. Because again, if you're dealing with a smaller child, those pads are pretty big. So just try and position it over the heart as best you can. So other thing, once we've got the Zoll hooked up, we're going to see it's shockable and we're going to follow the prompts. And we can also consider naloxone if an opioid is suspected. So of course, CPR takes priority, shocking the patient takes priority. But if we're able to get access or even give it IM, we can give Narcan for suspected opioid overdose cardiac arrest. And the recommended dose is 2 milligrams. So for EMR, you can try it intranasally. There should be some circulation in the nostril. You could try it. It's worth a shot. And with that, for the EMR level, we want to contact online medical as early as possible without delaying resuscitative measures. So again, CPR is the primary thing we want to do. We want to keep that brain perfused, keep the organs perfused. But we also want to call online medical for either if we want to discontinue resuscitation or transport decisions. Because again, if there was CPR done by bystanders on scene, it was witnessed, that patient has a higher rate of survival. And there might be things that we don't notice that may be dealt with in the hospital that we can't deal with in the field. So with that, we have to look at calling online medical and have this discussion, because a lot of times we don't want to be transporting someone that's not salvageable, lights and sirens to a hospital, because that puts everybody at risk, the paramedics, the public, because we're going to be driving faster, and the person in the back, how effective is your CPR if you're driving that quickly down the highway? So we need to have those conversations with online medical. Is the shock advised? And if it is yes, we're going to perform CPR analyzed shock. So with that, we're going to do it up to 3 times. Do we get ROSC? If the answer is no, then we're going to resume CPR. Or if the shock is not shockable, we're going to resume CPR. If we do get ROSC, if we haven't already, we'd ideally like to secure the airways. So as EMRs cannot use iGels, we're just going to OPA and PA just out that oxygenation, ideally OPA at this point, and secure it and start ventilation and maintain a SATs within the normal ranges. So with that, we're going to ventilate. And we don't want to overventilate them. The big thing with that is with adolescents, and adults, we want to give one breath every 5 to 6 seconds. And for pediatric patients, we want to give one breath every 2 to 3 seconds. So we're going to want to try to maintain a normal saturation. In the guidelines here, it recommends for trying to obtain a SAT between 92 to 98% adults and 94 to 99% in pediatrics. So that'd be under 10. And the big reason for that is, again, number one cause of cardiac arrest suddenly pre-hospitally is hypoxia. So we want to try and get the SATs a little higher in our pediatric patients. But again, we want to make sure we're not ventilating too fast. So we want to make sure we're sticking with the regular guidelines as per heart and stroke of how often we ventilate these patients, because hyperoxygenating them is not going to be beneficial either. So then we're going to look at transporting. So if ROSC is achieved or not, we can consider transport towards close ED and try to consult with online medical if we can't get through while we're on scene. And then we're going to treat and transport as directed by online medical. And that's basic cardiac arrest. Next, we're going to look at is C02, advanced cardiac arrest. So this is for PCP and above. So that's just been renamed and reformatted. There's not a ton of new information here. It's just been reformatted, so it's one care map for PCPs and up. So as we always do with CPR, like we did with the previous one, even basic levels, open airway initiate CPR. And we're also going to take the patient's COVID status into consideration. If we are worried that they have COVID or COVID-like symptoms or ILI symptoms, and we're not really determined whether it's COVID or not, we're going to want to get an iGel in as soon as possible to help secure that airway. We're going to consider naloxone if opioid is suspected. So again, that's a reversible cause. So we get our good BLS going, get an airway secured. We can get the monitor getting ready to go, and we can consider naloxone. So we're going to test the monitor defibrillator and identify the rhythm, or use AD mode to analyze the rhythm and shock if indicated every 2 minutes up to 3 times. And again, like I said in the previous care map, the pad placement in the Joulage, we have to make sure if we got pediatric patients that we're using pediatric pads appropriately, and we have the Zoll set to pediatrics. That way, that if we're using AD, the Joulage is lowered. And we're going to give medications as required. So in the care map here, we have Appendix A, cardiac arrest. It's got your dosaging here. So if you're using AD mode, you're using AD mode, that's fine. But if you're doing manual defibrillation for 10 years and up, it has the Joulage guidelines. If it's less than 10, it's a weight-based shock. It also has an Appendix A. It has the dose for epinephrine and amiodarone. It does reference in this care map about dealing with hyperkalemia and torsades. So for those ones, you're just going to reference E11 for the hyperkalemic patients, which is a new hyperkalemia care map. And with that as well, if you need to find out the dose for make sulfate for patient torsades, you can look at medication document M24. So when it comes to reversible causes for these patients, so we're going to look at our H's and T's, and anybody's taking ACLS, I'm sure you're aware of these. So this is an Appendix B. So these are just different things we could think of that could be causing the cardiac arrest or reasons for possibly transporting this patient versus staying on scene. So we got hypovolemia hemorrhage. Obviously, we're going to deal with, we want to stop bleeding. So we look at C07.1. We got hypoxia. Again, make sure you're ventilating, oxygenating appropriately. We're going to combat that acidosis by doing good quality CPR, good ventilation, securing the airway. And we can also use end-tidal CO2. And with that, if we are getting end-tidal CO2 greater than 10 during cardiac arrest, ideally 20 is a better goal to go for, but it's greater than 10, you're getting good air entry, good chest rise, good compressions, that we're going to be combating that acidosis. So with that as well, it's got the hyperkalemia. So like I said before, we're going to reference E11. That's a new hyperkalemic care map coming on the 13th as well. So for hypothermia, again, there's that saying, they're not dead till they're warm and dead, which is technically true in this case. So we want to make sure that we're not doing the whole code in the cold because our meds aren't going to work and we need to warm the patient up. And if there's a tension pneumothorax, we're going to need needle decompression. That's not currently within the scope at this time. So that could be a transport decision, or it could be a request for a helicopter intercept. The cardiac tamponade talks about possible transient benefit from fluid bolus. So with that, it is recommended that possibly giving fluid to a patient that's got cardiac tamponade, we can increase the pressure inside the ventricles to overcome the pressure outside the heart that's crushing it. So that's a therapy we can consider. With tension pneumothorax and cardiac tamponade, for both of them, these patients have a high probability of being in a PEA because, again, this is obstructive shock. Also with that, we can see JVD. With tension pneumo, your bagging might get more difficult. And with cardiac tamponade, if you can't feel pulses and you know you're doing good CPR, that could be an indicator of cardiac tamponade because the heart's not actually pumping. Then you got overdose in there as well. So we got medication profile M11 from the naloxone that we talked about, and you also have M18 to give sodium bicarb for tricyclic antidepressant overdoses. MI is pretty straightforward. We're not going to activate STEMI though until we get ROSC. Pulmonary embolism. So we could try a fluid bolus just to increase the pressure in the lungs to get more perfusion. And with the trauma, we can reference the new F02.2 advanced trauma arrest. So you did all this, and did you get ROSC? If the answer is yes, yes. If you've not already done and secured the airway, we want to get an iGel at this point and just keep ventilating patients. And basically, when you get ROSC, you're just doing a full reassessment of your patient. We're going to support ventilations, the main O2 saturation, appropriate for the age guidelines, and as well as use our capnometry. So with that, normally when we get a patient that gets ROSC, we're going to get a big spike of end tidal CO2, and that's normal. So we're going to help ventilate and help lower it. So the best way, if you have a very high end tidal CO2 to help the patient blow it off, is we're going to increase our rest rate when we're ventilating. If the readings are really low, we might be hyperventilating our patients. So make sure we're hyperventilating, but not so much that we're causing them to go below 35. If you do find with your ventilations they're starting to get lower than 35, back off a bit because you're overventilating. So we want to guide our ventilations based on their SAT readings and their end tidal. When it comes to SAT readings, though, they can take a couple of minutes to update, whereas end tidal is pretty much instant feedback. So if we use the two together, that will definitely help with ventilation of these patients. If we haven't gotten IO or IV access already, we can do that. If they're really still in extremis, we can look at IO if we haven't had that already. And we're going to look at getting perfusion back to a systolic blood pressure of approximately 90 or mean arterial pressure greater than 65 in adults. I would strongly recommend, if you're looking at fluid administration, you look for their MAP as opposed to their systolic blood pressure, because that can be variable for the patient what actually a good systolic for them is, whereas MAP's a little bit more of a reliable number. And if you're wondering how to figure out where your MAP is, if you look on your Zoll next to your blood pressure, it's the little number in brackets, that's your MAP. Because it only talks about adult vital signs on the advanced care map itself, there is also this reference document H01, pediatric vital signs. This is in the care maps as well. And it doesn't have MAP in it, but it does have the average systolic blood pressure, average diastolic blood pressure. So if you're wondering if your patient is perfusing well enough, or you might consider a fluid bolus, you can reference this document as well. But just a side note, if someone was just dead like 30 seconds ago and their blood pressure is not great, I wouldn't be surprised. So make sure you keep an eye on it. Don't immediately just start dumping liters of fluid, because if their heart is having a time struggling to get going again, we don't just want to all of a sudden slam it with fluid. So just a consideration. Again, that's based on what the conditions are of the patient and the situation as well. So we're going to exclude hypoglycemia. So it's been proven that doing blood sugar checks during active arrest is pretty inappropriate. It hasn't been shown to really show any benefits when we do that. Also, if we do find a patient that is hypoglycemic, it's been proven in studies that if we give D10 during an active cardiac arrest, it's actually very harmful and it can actually cause organ damage. So it's really going against what we're going for. So we're not going to be doing that until we get ROSC. So once we get ROSC, and then we're going to be checking our blood sugars, that we could look at giving D10, things like that. If you're an ICP, you can consider giving amiodarone now if you haven't had a chance to give it. So if you arrive on scene, you get there soon enough, you start CPR, shock rhythm, you shock them, you get ROSC. You haven't given amiodarone, you can consider doing an infusion. So as per the amiodarone med profile here, it says ROSC, amiodarone not given during resuscitation. You can give it IV or IO. So with that, for 17 years and older, it's 300 milligrams over 10 minutes. For 12 months to 17 years, it's 5 milligrams per kg over 10 minutes with a max of 300. So the max is the adult dose. And this has to be given over 10 minutes. So you can do it one or two ways. You can give it by slow push in a syringe over 10 minutes, or you can infuse it into a 100 cc normal saline bag and give that over 10 minutes, making sure you calculate your drip rate appropriately. So with that, if the patient's stable enough, you can do a 12 lead and look at seeing if they need to go to the cath lab and transport as required. What if we don't get ROSC? So the big thing is we want to confirm asystole in 2 leads. The Zols are much better than older monitors, but it's still requested that we check in 2 leads to make sure that they're actually in asystole, not just in a fine beat fib. So don't just call it based on pads. We're also going to use our leads and get different perspectives and different views from our Zol. If there is asystole in 2 leads and there's no other differentials to consider, ICPs can choose to discontinue in the field. If there's any other questionable circumstances, by all means, as an ICP, you can still call online medical, especially if your patient had improved electrical activity. We should probably make a phone call to see if they want to transport or not, or if there's something reversible, like possibly a tension pneumo. PCPs have to contact online medical support prior to discontinuing resuscitation. That's not an option. You need to confirm with the physicians that you are okay to discontinue resuscitation when started. If it's not asystole in both leads, there are any other clinical factors or other reasons to continue, such as listed in Appendix B, so that's your H's and T's, or again, improving electrical activity, or in a pediatric arrest as well, that's a consideration. If no, we're going to consider discontinuing. If yes, we're going to transport and consult online medical. So we're going to continue doing high quality CPR and continue administration of epinephrine as required every 3 to 5 minutes with constant reassessment as we transport this patient. And that is our advanced cardiac arrest care map. So again, not a lot of new information in there. It's kind of a bit of a review. It's just been reformatted so PCPs and up can reference just one care map instead of 2. So the new addition here we have is F02.1 basic trauma arrest, and these are for EMRs. And there is an advanced one as well, which we're going to go over again. We're going to go over after this one. And these are brand new care maps here. So indications to use this care map is cardiac arrest due to major traumatic injury. If it's non-traumatic, we're going to go to the EMR basic cardiac arrest care map that we just reviewed. So contraindications of this, same as the other one. So obviously, if they have a DNR, we're not going to start resuscitation, or if they have injuries incompatible with survival. So especially with trauma, if they got massive head wounds, their chest is open, things like that, they're rotting on the sidewalk, like we're not going to start CPR on these patients. So as we discussed before, again, it's CPR. The big thing we were going to look at is we're going to look at controlling C-spine because there is a lot of movement when we do cardiac arrest. So we want to make sure that their neck is protected so we don't cause secondary spinal injuries. The other thing as well is we're going to stop any bleeding. So it's that whole X ABC. So X, we want to tourniquet, stop bleeding, things like that. And then we do our airway breathing circulation. So we want to make sure we stop the bleed because if we're doing CPR and the blood spraying out the patient, it's 100% ineffective. So we need to control that bleeding as well. So this is going to be very busy for you and your partner, where we're going to have one person attempting resuscitation while another one is preventing the bleeding. The other things you can think about to help reduce bleeding, so we could look at applying pelvic binder, especially if we think the patient's got an unstable pelvis. We can be bleeding out of the pelvis. So obviously if we're doing CPR and we're just pushing it all into their belly, it's not going to help. So we want to apply a pelvic binder. And the same thing with long bone fractures. It's just straight up, we're going to splint as best we can just to prevent fluid losses. If you haven't already, then we're going to start CPR and then we're going to attach the AED as we do for normal CPR resus, and we're going to analyze the rhythm. So again, using the age-appropriate pads and the proper placement, and using the Zol on either pediatric or adult mode based on the age of the patient. Just a side note, if they are 10 and under for trauma or for regular cardiac arrest, 10 and under, the Zol should be in pediatric mode, no matter whether you're doing a resus or just doing an IFT. So with that, a new thing that's been added in here is we're not going to call online medical support for these patients. We're going to call online trauma support. And when you call into dispatch, you need to make sure that you differentiate between the two. So we want it that way they know kind of what we're going for. So we want the online trauma support for EMRs definitely has to be consulted prior to discontinuation, unless of course they've got those major injuries that are incompatible with life due to trauma. So the decision to transport a trauma patient may be complicated because of the injuries and severity of the injuries, as well as downtime before EMS arrives. So if you do put them on the monitor and it does say shock advised, we're going to shock them as per and continue up to 3 times. Did we get a pulse back with that? If no or no shock advised, we're just going to stick with our CPR. If we do get ROS, that's awesome. If it's achieved, we're going to secure the airway if we haven't already. So again, EMRs are not permitted to use eye gels anymore, so OPA, NPA would be great. Again, worrying about NPAs and head injuries, we might want to be cautious with that for trauma arrest. And we're going to support ventilations to maintain appropriate SpO2 readings. So if the patient is still receiving CPR, we did get ROSC, we're going to consider transport to closest ED, and we're going to consult online trauma support during transport. And then we're going to treat and transport as directed. And that's the basic trauma arrest. Next one we're going to look at is F02.2, which is advanced trauma arrest. So this is for PCPs and above. So same thing as advanced, just regular cardiac arrest, it's PCP and above. So we have a basic and we have an advanced. So with advanced trauma arrest, this is for PCPs and above. So again, indications, so if someone's in traumatic cardiac arrest. If they're not in traumatic cardiac arrest, we're going to reference C02, advanced cardiac arrest. And same thing as the EMR level care map. So if there's contraindications, if they have a DNR, they're obviously just destroyed. There's no injuries incompatible with survival. They're completely incinerated. Then we can go to this care map. We're not going to start resuscitation on these patients. So as with most cardiac arrests, we're going to open the airway first, and we're going to take COVID precautions into consideration and always secure the seat collar. Because again, just like the basic one, we want to prevent secondary spinal injuries. And like mentioned in the basic one as well, we want to stop any external bleeding. And with that, if we have limited resources in the gut severe hemorrhaging from extremities, just use a tourniquet. We're not going to try dressing it, things like that. They're in arrest. So we just need to stop the bleeding as soon as we can. And as I mentioned before, we're going to apply a pelvic binder, help control that abdominal bleeding, and we're going to splint long bone fractures as well, just to help prevent ongoing fluid loss. And it's very similar here. We're going to start CPR. We're going to put the pads on, age-appropriate pads, age-appropriate placement, and make sure you're all set on pediatric versus adult, and we're going to shock if they have a shockable rhythm. With that, if you have a patient that's in asystole, when it comes to traumatic arrest, the chances of survival are very slim. But if they are in VFib or VTAC because they took like blunt force trauma to the chest, it's right, like took a steering wheel to the chest, they have a higher chance of survival if we shock right away. So we still want to make sure we're checking these patients if they have VFib or VTAC without a pulse. Other things we can do as well, we can consider epinephrine every 3 to 5 minutes. So let's say we did put them on the monitor and they did have asystole in 2 leads. Like I said, their chance of survival is usually not great. So as an ICP, you can choose to discontinue, or you can consult online trauma support. So again, with that as a PCP, if you want to discontinue resuscitation, you need to make the phone call. Again, make sure we're calling for online trauma support, not online medical support for these patients. So with that, if they are not in asystole in 2 leads, did you get ROSC? If the answer is no, are there other clinical factors or other reasons to continue? So again, are they severely hypothermic? Did we get the bleeding under control? Things like that. Are they pediatric? If no, we're getting an ICP can discontinue. But like I said before, PCP needs to consult online trauma support before you can actually discontinue resuscitation if it's on this patient. So if you get ROSC, and are there clinical factors and reasons to continue? If the answer is yes, we're going to initiate transport to closest ED and consult online trauma support during transport if we haven't had a chance to get a hold of them yet. And we're going to treat and transport as directed. Again, still controlling the bleeding, still doing good quality CPR, monitoring the rhythm. And again, it says you consider epinephrine as well. So that's something you consider en route if you weren't able to get to it on scene. Because if you haven't got IV access, now's the time to do it. So we can get that IV access, IO access, and consider doing epinephrine as well if they're still in arrest. If you're already done, so we can look at giving TXA for these patients once we get vascular access. So with that, we can give TXA in accordance with M28, tranexamic acid, and we consider IV fluids. So just with this one here, with TXA here, so if we're going to reference M28, so 12 years and older, it's 1 gram, and for 1 to 12 years, it's 15 milligrams per kilogram. So with this, we're going to set up a 100 cc bag, and we're going to administer it over 10 minutes. We don't want to give it too quickly because if we just hammer it into our patients, then that can cause hypotension, which is kind of defeating the purpose of what we're trying to do here. Now, like I said before, you can consider IV fluids. So with that, we want to do permissive hypotension because with that, even though they were in arrest, we don't necessarily want to just jam a lot of fluid in them because that can dissolve clots, it can dilute clotting factors, increase acidosis. And again, with patients, if we're looking, especially in trauma, for giving large IV fluid boluses, we want to go with ringers, not saline. Ringers has been proven to be more effective in trauma than saline. So with that, it's got the preferred systolic blood pressure for permissive hypotension. So if it's adult, it's 90 milligrams mercury, adolescents 80 systolic, child is 70 systolic, infant 60 systolic. If we're suspicious of head injuries and we want to keep that pressure higher, because again, if they have that increased intracranial pressure, it's putting pressure on the brain, we want to make sure we're perfusing inside the brain to overcome the pressure outside of the brain. So we want to kind of look at just getting a normal intensive. And again, we have, like I mentioned earlier, there is that regular vital signs reference document that you can look at if you're not sure of pediatric vital signs, or you can use a formula of 90 plus 2 times their age, and that would get you for pediatrics or normal systolic blood pressure. And that's F02.2, Advanced Trauma Arrest. Thank you very much for attending this session. And if you have any questions, feel free to email me at emseducation@irha.ca. Thank you.